Welcome to the sessions of Patients Today, where we will discuss a number of abstracts in the early and late stage lung cancer space, which were presented earlier this year at ESMO in Madrid. My name is Anne-Marie Baird. I'm President of Lung Cancer Europe, and it is really my great pleasure to be here today with Professor Solange Peters, who is the past president of ESMO and a medical oncologist at CHUV Lausanne University in Switzerland. Today, we'll be discussing the abstracts in two sessions, starting first with the early stage and then moving into the late stage space. So it's now my pleasure to pass to Professor Peters, who will start presenting the abstract data.
Thanks so much, Anne-Marie. I will start with the slides showing the disclaimer for the session of today and my disclosure of interest, the work we do with the pharma industry. As you said, we will start to look at these patients in this first part and chapter, these patients who can aim at the curative intent strategy and basically at these patients who are eligible for a surgical resection of lung cancer. This is a selection we have made of the abstract that we think, of course, will impact the guidelines, the treatment decision processes, but also maybe the accessibility and availability to new strategies very soon in many countries for early stage non-small cell lung cancer. So the first abstract is an interesting one because it's looking at a subgroup of patients. That's an important first thing to say. At a subgroup of patients who suffer from an early disease. Early disease in general, and you will see through all of these abstracts, usually means patients with or a lymph node positivity, can be close to the tumor, we call it N1, or can be already in the middle between the two lung called the mediastinum, so a bit more far than the primary tumor called N2. So lymph node positive, or in these trials where we do more than surgeries, this patient who have a pretty large tumor, even without lymph nodes, and pretty large is more than 4 centimeters. So all more than 4 centimeters, all because you have one N1 or one N2. So this is the subgroup of patients who were treated in this trial called ALINA, but it was interesting because ALINA was looking at these patients in terms of stage, but all the patients had what we call a tumor which was oncogene addicted, meaning that there was an identified oncogenic driver, a specific genetic alteration, which is driving all the characteristics of the malignant phenotype, invasiveness, metastasis, and this immortality of the cancer death. And this oncogene is the ALK rearrangement. So we know the ALK rearrangement since a while because usually in ALK, in metastatic disease, we would use a targeted therapy. So basically, in general, when you have a patient with ALK positive non-small cell lung cancer and a surgery, until now, we were applying the all-comer strategy, meaning surgery, and some patients adjuvant chemotherapy. This patient who had this characteristic of large tumor node positive, but with a very modest benefit. You cure 5% more of patients if you give adjuvant chemotherapy, but still, it's about cure. So the community thinks it's worse. But for ALK, until now, it was the usual chemotherapy. But we know from the advanced disease, as I said before, that at least in advanced disease, a personalized targeted treatment is better. And we have a series of these compounds. The first one to really establish was alectinib, an ALK inhibitor, is it called? And this is probably the most used today in advanced metastatic disease. So you see where I come from? The idea was in ALINA to compare after surgery this alectinib versus chemotherapy. So this is a very logical design. You have patients, and remember that ALK positive non-small cell lung cancer represents something like, let's say, 2 to 4% of our patient population. So the effort is huge because 257 patients were randomized to receive alectinib for up to 2 years, or the usual platinum-based chemotherapy, which is usually 4 cycles of doublet chemotherapy, 2 agents together. And the idea was to see how this 2 strategy performs in terms of disease-free survival. This is the primary reading we have. Of course, in the future, we will look at the overall survival. Okay, so this is the trial design. What is quite important to look at today is the magnitude of benefit, because this is the first interim analysis. So these numbers can still change a little bit over time. But we wanted to see, first of all, if there is an obvious benefit and what looks like being the magnitude of this benefit. So the reason why it was immediately presented and also created a kind of enthusiasm in the crowd is that the magnitude is huge. When you compare in these patients, the strategy, so if you look at the highest risk, so what you call stage 2 and 3, meaning with lymph nodes positive, so going a little bit out of the tumor, the alectinib versus chemotherapy improves the disease-free survival with a hazard ratio of 0.24, meaning that you reduce the relative risk of relapse 76%, right? And if you look at all the patients, including the one without the lymph node positivity, it's still 0.24. It's a second column on the right. So the magnitude is absolutely huge. And probably one other thing that's for me and for patients might even count more. We know in ALK disease that the main risk of this disease is to have brain metastasis. We don't know why, but ALK-positive non-small cell lung cancer goes to the brain in up to 70% of the patients in advanced disease. So the risk is huge. So the main question when you give alectinib in the adjuvant setting is, do you prevent potential brain relapse after surgery, which is a drama for the patient, for the relatives, even for the physician. And here you can see it's the last line. The CNS, so central nervous system disease-free survival, is even better than the systemic disease-free survival with a hazard ratio of 0.22. So 78% of the patients are relatively preventing for having brain mets if you receive alectinib versus chemotherapy. So very, very impressive data. Of course, I have to measure some more and we'd like to see survival. But, you know, looking at this outcome and knowing about ALK, it might be that reading of survival will come in some years from now. So it's good to have this data today. This is what the curves look like. So the benefit is immediate, right, from the very first assessment. And as you can see, there is a widening of the interval between the two treatment groups over time, a proportional hazard ratio. So something very clear for us in terms of disease-free survival. Look at immaturity of data. We have only 2% maturity. So imagine how long we'll have to wait to have the final overall survival reading. If you look by stage, maybe thinking, the main benefit is seen in patients with a higher risk of relapse. So the answer is no. All stages benefit. Stage 1, lymph node negative. Stage 2, stage 3. Stage 3 is with very central lymph nodes to be positive. So you can see, honestly, the benefit is seen in all subgroups. And this is the brain. So of course, there are still few events, and unfortunately, there are still few events. But the difference between alectinib and chemo in terms of brain relapse, even if there are few events, if you look at the proportion of relapse, it's amazing how much alectinib is preventing them, with almost no events at the time being, only 4 in the alectinib arm in the 130 patients, right? Safety, we know that, right? Because we know alectinib since a while, it's a very well-tolerated compound. So giving it in the adjuvant setting is not a problem because it gives rise to a very low toxicity, very often laboratory to control, liver test perturbation sometimes, so more something to be seen by the doctor. And sometimes it gives some muscular pain. So that might be a problem, and that has been described. But it's very rare that it leads to discontinuation. As you can see here, it only led to discontinuation is 5-6% of the patient population. And it was 2 years of treatment, right? While chemotherapy, which was only 3 months, gave rise to 12% discontinuation. So we know the toxicity is well tolerated. So basically, a high and significant improvement of what we call disease-free survival. The brain, the CNS is also protected the same way by giving alectinib. Overall survival, we'll have to wait an additional years. And alectinib is the first compound to be tested in this rare disease entity after surgery. So it's really, for me, a meaningful benefit. What does it mean for everyday treatment? So we know we had the same trial. It's important to keep it in mind in EGFR. And in EGFR, we did with almost the same design. We had this discussion, but DFS is not OS. And in EGFR, waiting enough, the EFS, which was even less than this one in terms of benefit, it did translate into an overall survival benefit. So looking at the sister trial in EGFR, we are perfectly confident that down the road, it will translate into a survival benefit. The only question is how long do we have to wait? But no doubt it will be a survival benefit. Of course, survival benefit does still not mean cure. You can survive longer and still relapse some years down the road. But I'm not sure that this speaks to patients, and Anne-Marie has to tell us about it. But surviving without brain metastasis, even if it's not cure, if it's about years, I think it makes sense per se. But that's really an important thing. We have 2 years of alectinib in that trial. In the EGFRs, they gave 3 years of osimertinib. It looks like to be a little measured without real data. That's probably true. So some people already complain that 2 years might be too short. I don't know. Nobody knows. And last but not least, I think for me, the most important data here is to prevent brain metastasis, which is absolutely unacceptable for a patient to suffer from. So that's my take-home messages. For me, it's a new standard. And if we could have access to that, it would be nice. The community is struggling with one thing is we love chemotherapy. We love give adjuvant chemo because we have been increasing cure. So some of the doctors, probably I'm among them, I might propose to the patient to give the adjuvant chemo with this 5% cure rate in addition, followed by alectinib. But that's not what the trial was questioning, right? But sometimes in oncology, we like to do more. So some doctors might do both, right? But that's for me a new standard. What do you think, Anne-Marie?
Well, I think it was really exciting to see so much lung data come out at ESMO, and so much of it is so promising. And I guess from an advocacy perspective, it's all about translating all of these advancements and developments into the real world setting. So I guess to kick off, just 1 or 2 very basic questions, if that's okay, Solange, and then to talk a little bit more about the data. So you've mentioned a lot in terms of the adjuvant setting. Some people may not understand that term. Can you explain what that term means in terms of this study?
It's very important because even my young doctors make it wrong sometimes.
Okay.
Adjuvant really means that's a very specific setting, right? Adjuvant is reserved to early disease. So a disease which are not spread outside of the original organ, the breast, the lung, or whatever, and the located lymph nodes. Remember, lymph nodes are the filters which are localized near to the organ and are supposed to clean the rest of the body from the spreading of any kind of disease and infection and so on and so forth. These lymph nodes are also supposed to help mounting an immune response. But basically, the adjuvant is only for these diseases which are confined to the original organ plus the draining lymph nodes, right? And not gone elsewhere. And this tumor must have been treated by surgery. So adjuvant means you have a complete resection of the tumor and the lymph nodes, no disease visible, not a single sign of the disease, so everything looks clean, and you give a treatment, a little blinded, right? A little blind, you give a treatment to prevent the risk of relapse. So basically what you do is you treat invisible micrometastasis. And very often you have to realize you probably treat nothing because the patient is cured, but you do it a kind of a preventive methods, right? But probably in that setting, in breast cancer, 90% of the ladies are already cured. In lung cancer, it's less, probably 50 to 60% of these patients are cured. But you have to understand that giving adjuvant treatment is treating invisible potential micrometastasis. So meaning that sometimes you have to treat patients who don't have this micrometastasis. But everything which is in advanced disease or which is in the case of a disease is not resected. It's not called adjuvant, it's called consolidation, complementary, maintenance. It's not called adjuvant. Adjuvant is surgery, nothing visible.
Well, that's great to have that clarification because a lot of the terminologies can be quite confusing. And I guess my next question is really, you mentioned in the advanced setting, you see about 2 to 4% of people presenting with ALK-positive disease. And because traditionally, molecular testing wasn't done in the early stage space, do you think you'll still see about 2 to 4% of people testing positive for an ALK rearrangement in their tumor in the early stage space? Because, as an advocacy community, we're just wondering how many people could possibly benefit from this.
So here there are probably two questions. Do we have any reason to think that in general, scientifically, right, the proportion of ALK positivity in a disease which is small would differ from in a disease which is metastatic? And the answer is probably no, because these drivers have this characteristic of driving the disease completely from A to Z, right? So probably if you take a group of patients, whatever the stage of the disease, the proportion of these drivers should be the same, and it will unfortunately stay active the whole course of the disease. So we are supposed to be able to diagnose 2 to 4% of ALK positive in early disease. Would we adequately test? So the main question here is how to test to make sure that we don't miss them. So ALK is a good one, even better than EGFR, because ALK now can be really evaluated with a very cheap and easy way by immunohistochemistry. So we'll discuss it later on, but now when you have an early disease, of course, the pathologist will look at the fixed tissue, right, at one slide with your tumor. First of all, to establish the diagnosis of cancer. So second is to try to tell the subtype of cancer, squamous or non-squamous. And to do that, very often he uses some staining with antibodies. It's called immunohistochemistry, just to tell the type of lung cancer it is. And he will do 2 as a test. One is PD-L1. This is a biomarker for predicting the activity of immunotherapy. And he can also do ALK. ALK is a simple immunohistochemistry. And in case of ALK positivity by immunohistochemistry, you can be confident it's positive if it's well done. So basically, this is the biomarker easy to establish. But I agree with you. In the past, we were not doing it in early disease. So it has to enter the routine in terms of a diagnosis in early disease in every non-squamous, non-small cell lung cancer, regardless of the stage, right? But fortunately, it's not an expensive test. It's an easy test to do.
Which is also great to know, because obviously you do need that access in order to make the difference. And then to your question around the brain metastasis, obviously that is a huge issue within the community. So any possible treatments that could help in any shape or form in terms of brain mets is going to be something that's positive for the community. So I'm just wondering, in terms of the balance of, you know, these newer drug treatments and balancing that with quality of life issues and side effect management, do you feel that that balance is there, that the kind of the adverse events we're seeing versus the benefit it is acceptable in terms of, you know, you did show some data on the adverse events, but in someone who's receiving this as a trial or in like real life, are there supportive measures in place to help with those side effects so that people can stay on those drugs longer, if my query makes sense?
So the answer is absolutely yes, particularly in that setting where alectinib is really well tolerated. It will be very important to see all the quality of life and patient-related outcomes data at the end of this trial, which are collected. But I have really no doubt that this is maybe even a better setting than EGFR. At the time, we had the same sister trial in EGFR. The toxicity of the drug used in EGFR is not completely trivial, right? But at the end, we still, with the patient groups, made the conclusion that it's worse to use a drug despite the side effects because it really prevents relapse. And here, alectinib is even better tolerated. So I would say the risk-benefit ratio is even better here than in the sister trial with EGFR. And by the way, the risk of having brain mets is even higher in ALK than in EGFR. So everything speaks for a higher relative benefit of this strategy. And, you know, we always have this discussion about survival, cure. But I had this patient who one day told me, you know, you tell me, of course, you could also not give it and wait until the disease is metastatic. And when the disease is metastatic, then you can receive alectinib, right? And it works very well, for sure. But this patient was telling me it's not the same thing. To have received surgery and be disease-free for 1, 2, 5, 10 years, then having received surgery, developed a metastatic disease, and being under a good treatment controlling the disease. Your life is not the same. In the first scenario, you are cured. You are still in remission of a disease. In the other scenario, you are in partial remission for a disease which is metastatic. And I'm not sure your life is the same, right? And I perfectly perceive it. I can perfectly understand it. Maybe also to close that, I met one friend who was diagnosed with EGFR mutated non-small cell lung cancer in Madrid. She's slightly younger than me. She had a small disease, 4 centimeters without lymph nodes. And I was wondering, how does a physician react when suddenly he is in this situation, right? So, of course, she did the surgery, she did the chemo, and she will take the EGFR because she's EGFR and the EGFR treatment. So we are also convinced as being physicians that that's the way to go. And it was interesting to see this friend because she was really applying this conviction to herself, right? So that's really something which has to be taken as a new paradigm, I think.
Yeah. Well, I mean, I think it's always all about, seeing the advancements, making sure they're understood and translated properly within the advocacy community, because it's all about then empowering people with the disease to be involved in shared decision making in terms of what's right for them, what's best for them, what their treatment goals are, which is really important. And I guess my last question before we move on to the next abstract, and it might be a difficult one to answer, but this data is so promising. When do you think this sort of treatment regime might be a reality for people with early stage ALK-positive disease in the real world? How far off do you think we are from that?
So it depends where you live, unfortunately, and that's the drama we have nowadays in Europe and across the globe, right? I'm quite convinced that all the regulatory bodies, FDA first, but very soon the EMA, also with the experience of the sister trial in EGFR, will give approval. So, of course, they will give an approval, which will be conditioned by default by the later follow-up and reading of this data. But the magnitude is so big that I'm sure the EMA will rapidly, probably in the next months, grant approval. However, in Europe, we still have a non-consensual system of payers, the HTAs, the Health Technology Assessment Assessors, which vary so much from one country to the other one. There are financial considerations, there are criteria being defined at different levels in each HTA, which means that in some countries it can take 0 days, like Germany. Germany follows immediately EMA. And there are some countries where now it takes 2 to 3 years, like France and other countries, maybe UK too. So the risk is really to understand that today in Europe, the payers might be slow in approving and registering the real reimbursement and availability to a compound. There is a European effort to try. There was one which failed, UNITA, to reunite all these HTA, hoping that they might make the same decision, meaning that at least everybody's treating the same way, right? Which failed because countries like to have their superiority or like to have their decisions being in the hands of the countryside. But now the effort is put again on the table. And we try to find maybe not a unique structure, but a kind of a consensual way to decide. So not one structure, but one decision. But it's still not now. So for this alectinib, there will be discrepancies between countries. And I find it's perfectly unfair. That's what we have in Europe.
It is very difficult that, your outcome is really dictated by not only where you live, but your socioeconomic demographic as well. But we have to keep our fingers and toes crossed that there'll be a joined up dot type of scenario going on where that, all of those barriers that we're talking about here can be worked around in some way so that they can be available to people who would benefit from it. So Solange, I'll ask you now if you'd like to move on to the next abstract that we've chosen for discussion.
So the next abstract is about these patients. Let's be very clear. We change the subgroup. We take this patient who have no oncogene addiction. So this patient who have the usual old days lung cancer, which is not the one of the never smoker, very young patient, but the patient who most of the time have a history of a smoking exposure, or as we know from Charlie Swinton, very high level pollution, something damaging the lung time after time. So in this patient population, the innovation in early disease, again, we speak about surgical patients with the same disease, a large disease or a lymph node positive disease. In these trials, they use the new classification. So the name of the stage changed a bit. However, it's the same stage, more than 4 centimeters or N1, N2 disease, as I said before. In these patients who have no oncogene addiction, the paradigm is immunotherapy. How can we do more than the usual surgery plus adjuvant chemotherapy using immunotherapy? So we have many trials in this field. and we have new trials being shown at the ESMO meeting. Until now, we had a kind of, I would say, we had trials which were opposing two strategies. One strategy was to give adjuvant chemo plus adjuvant IO, so giving everything after surgery. We have defined adjuvant before. And the other strategy was to give everything before surgery. So chemo plus immuno before surgery. So really opposing the before to the after. But the new generation of trials we have now are looking at both. Okay, there is a marketing issue here, but the idea is here in this trial to deliver chemo IO first, surgery, and more IO afterwards 1 year. So they combine all in all, it's a whole pack, you know, the whole package. You give IO before and after. So one of these trials, and we still don't know if it's needed to have so much IO. But that's what the trials are proposing in this ESMO meeting. So the first one is nivolumab. So nivolumab, we know now nivolumab was the trial which was providing benefit in patients who received chemo nivolumab before surgery. So only before. The idea in this trial is to give before, but as I said before, to add 1 year of immunotherapy. So not only chemo IO before, but chemo IO surgery plus 1 year afterwards. So 1 more year. And this was a trial, very easy to understand, no oncogene addiction. You have understood everything about the stage. So you give in the control arm on the right, chemotherapy for 4 cycles, followed by surgery, followed by placebo. In the experimental arm, nivo chemotherapy for 4 cycles, followed by surgery, followed by 1 year of nivo. So a lot of nivo, and the other arm, just the placebo. The primary endpoint is event-free survival. Of course, you remember in everything we do in lung cancer, the magnitude of benefit is defined by PD-L1. So you need to stratify always by PD-L1. We have 3 categories in lung cancer: negative, intermediate. Intermediate is 1 to 49 of the cancer cell express PD-L1, or high is more than half of the cancer cell express PD-L1. So low, middle, or high PD-L1. And of course, you have also to stratify by stage, because the stage 1 will not have the same outcome as the stage 3. So it was well done, well conducted trial, okay? But really the whole package, right? A lot of immunotherapy. So here you can see the numbers. So basically, it's very easy to read. The event-free survivors, the median was not reached in the immuno arm. It was reached 18.4 months in median for the chemo and placebo. You can see also what is interesting is at the time you perform surgery, how many of these patients have no tumor left. No tumor left means PCR, pathological complete response, meaning that your pathologist is looking for a single cell of cancer remaining and he cannot find it. So there's no tumor left. And it was 1/4 of the patient in the immunotherapy arm. And the usual, we know about it, 5% of the patient when you give chemo. What we know for this pathological complete response is a bit like breast cancer. We like it because it defines a good prognosis. When you have no tumor left in the surgical resection, then your prognosis is really better. Doesn't mean no relapse, but very low level of relapse. Is it worse in this patient to give more immunotherapy? Nobody knows. Maybe it can even lower a bit more the risk of relapse. But anyway, it's a good prognosis to have pathological complete response. So this is the curve. The patients benefit very early, even at the first assessment, of the nivo chemo versus placebo. And of course, the curve starts at the first cycle of chemo IO before surgery, and it goes up to the end of immunotherapy. So as you can see, the risk of relapse is reduced by 62%, meaning this hazard ratio of 0.58. So it's really in the range, probably slightly better than the strategy which we're looking only at adjuvant or only at neoadjuvant. But of course, you should never compare one trial with the other one. But very, very interesting event-free survival. This is about pathological complete response. We also use another parameter. I don't want to stop on it because it's not very useful, the major pathological response, which means few tumor left. But on the left, you can really see PCR, that this absence of tumor is seen in a wider group of patients when you use immuno. Okay. Toxicity, we know it. when you give IO, you have a bit more toxicity in terms of immunotherapy-related toxicity, rash, fatigue, diarrhea mainly, rarely high grade, some problem of the thyroid also, but very, very rarely annoying and high grade immuno. We know how to deal with this toxicity, but it's slightly more. Importantly, in the past, we were fearing that giving IO might prevent surgery. And that's not the case, right? When you give IO before surgery, everything about surgery is somehow improved. The resection rate, the facility and the ease you have to resect, the minimally invasive procedures, the extent of surgery and the timing of surgery, the duration of surgery. So I think IO is not a problem for surgery. The other way around, it improves the surgical process. So basically, giving this whole course, the whole package of immunotherapy is a good way to move. We have now, it's important for you to know, 3 large perioperative like this one. And I told you before, 1 neoadjuvant trials which show benefit. So how much IO do we need? We don't know. We don't know when we need 1 year of adjuvant. Maybe we need less, maybe we need more. We absolutely don't know. But there is, to us, a very strong rationale also for melanoma to start the IO as soon as possible. So we don't know how long, but what we probably know is the story of neoadjuvant giving the IO at initial diagnosis when the tumor is here, when the immune system is fit in order to make them both meet, really makes sense. So we don't know how much, but at least neoadjuvant makes sense. We have the feelings that the neoadjuvant is also good because the compliance is better. Patients are more willing and more also prone in terms of general health to receive the treatment in neoadjuvant. But of course, the main constraint for all of us is if we want to give neoadjuvant and maybe perioperative, but more importantly, neoadjuvant data, neoadjuvant treatments, we need tumor boards, right? Because you need to meet the patient before the surgeon performs surgery. So we need that every single patient is presented at a multidisciplinary tumor board with the decision of starting with chemo IO. And this is not the case still in many European centers. What do you think, Anne-Marie?
Yes, so again, really, really interesting data. And I have to say some of the questions that I was going to kick off with, you've already answered through your explanations, particularly a lot of those terminologies. So again, it's really exciting to see more data coming out within the space on immunotherapy. But I guess as we did for the last abstract, if I could start by asking maybe 1 or 2 more basic things and then go into the data again in more detail. So again, it comes to a terminology. So you've explained very eloquently neoadjuvant and the meaning, but you've also used the term perioperative. What is the difference between something that's perioperative versus neoadjuvant? Because you'd sort of assume they're both before as such.
Yeah. So if you want to have a common, we had to, by the way, we invented the vocabulary, right? And it's maybe not completely at the time being homogenized, but we wanted to make sure we understand what we speak about. So we really have made 3 definitions. Adjuvant, I told you before, it's complete resection. What you give after is adjuvant. The other way around is true for neoadjuvant. You give something before surgery, and surgery is the last required intervention. So neoadjuvant is a treatment which is given only before surgery. So adjuvant is only after, neoadjuvant is only before. And you speak about perioperative when you use a strategy before and after. So what I call the whole package, right? Before and after. So neoadjuvant versus adjuvant versus the whole thing, meaning before and after. And this trial, the 70-70, the checkmate is perioperative because you have before and after.
That's perfect. And then the other thing just to ask you that some of the listeners might be very interested in, you did use the term placebo when you were showing kind of that outline of the trial design. So for a lot of people, placebo can have quite a negative connotation because they feel that they're not going to get anything of any benefit within their trial setting. So in terms of this trial, when you use the terminology placebo, can you say a little bit more about that, Solange?
Yes, that's a problem, the placebo-controlled trial. That's a problem to explain, but also sometimes to conduct. So the idea in the placebo, the idea to use a placebo, which I agree with your colleagues, placebo is just water, saline water, right? But the idea is to make sure that if you have an intervention you are unsure about, meaning that, for example, for this trial, when it was started, we didn't know if immunotherapy would provide a benefit or maybe a detriment, right? It can sometimes produce a detriment. Imagine the patient cannot undergo surgery or something like that. So when you don't know if an intervention will be of benefit or detriment or neutral, you need to make sure that you look at your result objectively. And in terms of caregivers, right, particularly us, when it's not survival is black or white. You are alive or you are dead. But when it's about looking at a CT scan, telling, oh, it's slightly better, or it's slightly worse, or when you look at the CT scan telling, is this nodule a little foci of infection, or maybe a tumor which is progressing, you might be biased, because if you are in an arm with a new compound, you might say, oh, the scan looks good. And if you are in the control arm, you might say, oh, the scan looks bad, because we are all biased because we want to believe in what we do. So the only way to avoid the bias on the patient side, on the practitioner side, on the caregiver side, is not to know if the patient is receiving the new drug, the fancy drug. So that's the only way to be able to test objectively, is to give exactly the same injection in terms of practice to the patient receiving the experimental treatment or not. So that's placebo controlled. There is a flaw in that. For example, in the trial, there was 1 year of adjuvant nivolumab. So it means that in the intervention arm with the fancy drug, the patient was coming every 3 weeks, right, to receive the drug, which is fine. But remember that in the control arm, the patient was coming every 3 weeks to receive saline, right, to receive water. So, of course, that's the only way to produce nice data. But I can understand that it can somehow create some questioning about the constraint we impose to the patients. On the other hand, what I always tell to the patient is, at least it secures a wonderful follow-up of all patients, way beyond what the daily usual care would provide. So at least the follow-up is more than optimal. So we put some constraints, but we offer an amazing follow-up. So, but I understand the limitation of placebo. It's for the integrity of the trial, and it might cost constraints for the patient.
Well, I think you've given a great explanation, because obviously you don't want that bias to come into play. So therefore, everybody has to go through the same sort of procedures in a sense. So I think that makes it much, much clearer to people as to why you would do that in this setting. So thank you so much for that explanation. I guess my other question to you around the data was going to be around the IO before surgery and whether or not it prevented people going on to surgery. But you've also discussed that, showing that there's actually many more benefits, and that it wasn't a case that if people had side effects from the IO that they weren't able to then go on to surgery. Within the trial, was there any sort of numbers where maybe people had issues with the immunotherapy and then didn't make it on to surgery, or did everyone within the trial who started on the IO make it to the surgery stage?
So the answer is quite interesting, because this is worrisome, and some would say we should have anticipated it in all of these trials, where you give neoadjuvant treatment, chemo or chemo IO in these trials particularly. There are some patients who are enrolled, do 3 or 4 cycles of chemo or chemoimmunotherapy. There are some patients doing that, not reaching surgery. So you would ask me why? So 9–10% of these patients have, unfortunately, disease progression under chemotherapy, under chemoimmunotherapy. So this is the reality. 10% progress when you give the treatments. We don't know who are these patients who will progress, and do we have a way to think or to prevent them to be treated this way, to start with surgery and then give the adjuvant the other way around? We cannot predict. And basically, maybe it's defined disease biology, which anyway will recur. But we don't know. 10% of the patient progress. So that's why it's very important to keep a close eye on the symptoms and so on. The other 10%, because altogether it's 20% of these patients who don't go to surgery, the other 10% are strange. They are decision related. So at some point, the physician or the patient say, no surgery, please. So this is more for me about the incentive of the clinical trial. And that's something we do not observe in real life. Probably this trial was so attractive that we have pushed in this trial some patients who had unresectable or very marginally resectable tumors, because we were believing in the strategy, right? And unfortunately, at the time of surgery, they were not resectable. So I think one of the bias, this additional 10%, is about treatment decision and really offering surgery to the right patients. Remember, because if you cannot perform surgery, radiation is a very good alternative strategy in that patients, right? So I think, yes, 20% don't go to surgery, 10 can be prevented being smart and providing to the patient the right decision. And unfortunately, 10% are progressive disease. For sure, this patient will receive radiation at that time and might also be cured by radiation, right? There is a salvage therapy, but that's the reality. And by the way, these numbers are always a little lower with the immunotherapy, right? So when you use immuno, you still more or less the same, but slightly lower with immuno as compared to chemo only, right? So it's not the fault of immuno, it's the fault of the disease.
Yeah. And my last question before we move on to the next one, and again, it might be a little bit of a hard one to answer, but do you think we're ever going to see a space where we're not going to need that combination of chemo and immunotherapy? Because, you know, within the community, chemo tends to have a bit of a bad reputation, whereas immunotherapy is seen as something that is more disease changing in comparison to chemotherapy usually. Do you think we'll ever reach the point where we'll get rid of chemotherapy, or is it something that's here to stay in various combinations with other therapies?
My feeling is that in advanced disease, there might be a time where we reduce the old days chemotherapy component, or we postpone it to very late lines of treatment. So I have a kind of a hope that there will be less chemo in the context of the palliative setting of metastatic disease. However, in early disease, chemotherapy has shown to really give rise to cure. So these patients who, if you look 20 years down the road, are cured, meaning no sign of relapse, nothing. This was only shown with chemotherapy today. So I think this conservative idea that chemo plays a very specific role when you want to cure a patient will remain for some other decades. So to your question is, are we going to get rid of chemo in that setting of early disease? My answer is, I don't think so. Not yet.
Okay. Thank you so much, Solange. So with that, we'll go on to our third and final abstract in the early stage space.
Yeah, absolutely. So this is going to be an easy one, because it's just reproducing what I have shown before with nivolumab, because that's I would say, even the twin trial. I told you there are 3 perioperative, remember, before and after trials, and this is the twin trial of the one that we have seen before. This is the Keynote 671. So as a patient, you understand Keynote is not nivolumab, it's pembrolizumab, but the idea is the same, right? This is a phase 3 study looking at event-free survival and pathological complete response, and randomizing patients, a large number, 800 of patients, same stage of the disease, no oncogene addiction, like exactly the same as the one I presented before, but the only change is it's not nivolumab, it's pembrolizumab. Easy to understand. And they look at the same, of course, the timings, the patient population is slightly different, but the idea is exactly the same. So the whole package before and after chemo, IO before and after 1 year of IO. Nothing here new. But what is new is this trial is more mature and was able at the time of the ESMO meeting for the first and very first time to show survival data. So survival means you don't only prolong the time where you don't show a relapse, but you prolong the survival of patients. It still doesn't mean that it's cure, but you prolong survival, meaning that it's not depending on whatever you do afterwards, whatever you do when the patient relapse, still you have a benefit by starting with chemo, immuno in that setting, right? When you look at survival, it means that you cannot correct it down the road. You have benefited the survival of your patient. So here you can see we have the 36-month overall survival, 71% for the IO arm, 64% for the placebo arm. And this is a reduction of the risk of death of 41%, meaning, or 72, I do it again. It's a reduction of risk of death of 28%, so a hazard ratio of 72, and reduction of risk of relapse of 41%, this hazard ratio of 59. So you have a fourth less death when you give immunotherapy. And again, it's important because it really speaks for the whole journey of the patient survival, right? Whatever you try to manipulate afterwards, that is the survival which is affected, right? Toxicity is as foreseen, but that's the very first trial showing a benefit of immunotherapy in terms of survival in the early disease. That is the survival curve. The real difference in the early disease, remember, starts somewhere around 1 year. At 1 year, you really start to see a difference in this patient who have received immunotherapy as compared to the other ones, which is quite interesting because it speaks for an immunogenic process, which lasts quite long, right? Because remember, the immunotherapy is given for 1 year after surgery. So it really speaks about what we call a long-lasting immunotherapy benefit, memory T cells, so the memory of your immune system, right? So very striking curves, of course, they will mature over time, but the first time we see a positive outcome. So, of course, this is survival. You can still discuss if survival means cure, but still survival means survival. I think this will be for the regulators, for FDA, EMA, and the various HTAs. It's still the holy grail, right? You improve survival. So I hope this will make this availability accelerated thanks to the overall survival benefits. What do you think, Anne-Marie?
Well, yeah, absolutely. I mean, as you say, because we've gone through the other abstracts at this point, particularly with the last one, it makes this one, I think, a lot easier for people to follow. But I mean, absolutely, it would be great to see this there in the clinic so that people can have the option to have this as part of their treatment and care. I guess my main question from the study release lounge is to some of the figures you showed earlier, where there was, I think, about 20% of people who had to discontinue treatment on this trial. And I think that was in the pembrolizumab arm. So I'm just wondering, not taking away from the benefit of the trial, but for those who were in that 20% group, what is sort of the next option for them within this space? Is it another clinical trial? You know, what is the next option for them when they would have to discontinue treatment in a situation like this?
It's a good question because we have created a new patient population, right? By all these adjuvant trials and the multiplicity of these adjuvant trials. We have created, well, of course, there are different reasons to stop immunotherapy. It can be toxicity. And then, of course, you have to wait the benefit and the risk of restarting IO later on if needed. But most importantly, we have created this population of patients who are treated with immunotherapy for early disease and progress under immunotherapy or very shortly after having stopped immunotherapy, because these patients are suddenly immunotherapy resistant. So it means that the whole paradigm of relapse metastatic disease, where you have to give immunotherapy as frontline with or without chemo, is ruined by the fact that these patients are immunotherapy resistant. So we have created a whole population of patients for whom a new strategy have to be defined when they relapse and they have metastatic disease, because we cannot use the old days immunochemotherapy because they are immunotherapy resistant. So the unfortunate answer is if they relapse, they have to receive chemo only, like the old days platinum-based chemotherapy, which is not very exciting, right? I would even say it's terribly not exciting. So let's keep it in mind, right? Today, the guidelines answer is chemo. In the future, we need to open trials for that. We have other immunotherapy compounds. You remember for melanoma, we have stronger immunotherapy like CTLA-4. So is there a window for giving chemo plus a reinforced immunotherapy in these patients. So really to try to change completely the way you give immunotherapy, because you need something more pushy, stronger. The other thing is antibody drug conjugates. You have this new class of drug. We'll discuss it later on in the second part. We have a real new class of drug, which might maybe be the ones to be given in that setting. So lots of questions. And today, these patients are few. Tomorrow, there will be a lot. So we need to find a way to treat these immunoresistant patients at the time of relapse.
So just to clarify then, Solange, and apologies if it's confusion on my part. So that 20% that had discontinuation in treatment, that was more that they developed sort of resistance to the IO rather than having some sort of adverse event that meant they had to come off treatment.
You speak about this slide here?
Yes.
So this is the toxicity of the treatment. So led to this, it's the adverse events. Remember, adverse event is not treatment related. So adverse event might be anything when you are in a clinical trial, including the car crash, right? So anything which happens to you and can be qualified during the trial. And these are this adverse event leading to discontinuation. So in this 20%, right, some of the patients might have progressed and some of the patients might have stopped because of toxicity, right? So usually in this trial, what you observe is basically, because remember that the follow-up is not very long, is half are adverse events and half are more or less disease progression. And in that trial, it was the case. Probably 10% adverse events and 10% were events due to the disease, right? The stopping of the disease, the new population of patients, right?
Yeah. No, that's great. I just wanted to clarify that in case anyone had any additional questions in relation to that. So thank you so much, Solange, for the great discussion on those 3 abstracts in the early stage space. And thanks so much for everyone for listening in.
Thanks to you.